So if we compare the overall etiology and the pathophysiology of both boys and girls, we will understand that delayed puberty is much more common in boys, but the likelihood of pathology is lower. So we need to be very careful in terms of not doing unnecessary workup in these scenarios because that can cause more confusion. So this was a 13-and-a-half-year-old boy with delayed puberty who was referred with a testicular volume of just 3 ml and pubic hair stage 1. So parents were concerned that there is delayed puberty. He was relatively short for the family with a normal weight. On investigations, he had undetectable LH and testosterone. Now, based upon this, the treating physician made a diagnosis of hypogonadotropic hypogonadism and advised a MRI head. Now, this was a very troublesome situation because parents were really concerned about not only the short term, but also in terms of the long-term future of the child and also whether there could be a pathological cause in that perspective or not. Now, if we can look at this case very carefully, we'll see that this is too early a age to evaluate for delayed puberty. He is probably going in more like a constitutional delay of puberty and growth, if at all anything. So this child should not have been worked up at all in this scenario. So I think this gives us an idea as to how so many cases where workup is not done, we are unnecessarily causing confusion in terms of evaluation. Contrary to that, we had the 16-year-old boy who presented with pubertal concern, who had an onset at 13 years. So puberty had started and then it stopped for 2-year period. At that point of time, when the child was seen by a physician, it was found that he had a testicular volume of 3 ml, which was soft. He had pubic hair development, which was a proof that there was a development to start off, and now the development has stopped. He was reasonably tall, and then he was labeled as constitutional delay of puberty and growth from that perspective. So this case scenario, in fact, if you look at it, there were everything which was going on, which was against the diagnosis of CDGP. This was a 16-year-old boy. Of course, there was the onset of puberty. The testes were there, and there was pubic hair development. The height was normal. So these are all against CDGP. So when we talk about that, we'll discuss about what are the pointers which go against CDGP. In this case, clearly developed and was found to have a brain tumor, which was causing these problems in that perspective. So this was a case in which we had missed the pathology. So in evaluation of puberty, which is a common scenario, 5% of all boys have delayed puberty. Physiological causes are common around 70% of cases. 30% have a pathology. What's important is that we do not do unnecessary workup in these 70% as was done in the first case, while we do not miss a pathology in the second case of 30%. This whole talk over the next 1 year, we'll discuss about the strategies about how to not do unnecessary workup while not missing on pathologies. All these resources are available in our website learning.growsociety.in, which offers a lot of resources as well as courses in pediatric endocrinology. We have our e-learning videos, so a lot of free stuff is also available over YouTube. There is option to look into our different courses, including fellowship courses in pediatric endocrinology and pediatric endocrinology for postgraduate courses as well. We frequently run grand rounds along with the PG lecture series and journal clubs to highlight these common scenarios. The books are available both online as well as the e-versions. Our app will help solve a lot of these problems. We'll try to see how it will help here. And today our focus is predominantly on delayed puberty in boys. Just a word about cancer. So basically what we're trying to say is that there is a differential effect of radiation on the Leydig cell and the Sertoli cell. So germ cells are affected at much lower, 0.5 grays, while Leydig cells may be preserved. So these children will have delayed puberty, but they will more likely to be sterile. So this is something we have to consider, that just puberty does not mean that they will be fertile. That's why we talked about semen analysis at a young adult age group. Three questions which a physician has to answer when they are managing a child with delayed puberty is it really delayed puberty? If it is delayed, is it physiological or pathological? And finally, what is the cause? So delayed puberty in boys is again a statistical definition. If there is no testicular enlargement by around 14 years, which is around 2.5 standard deviation score from mean, or there is a stalled development, we call it a delayed puberty. Importantly, do not consider penile size in delayed puberty because penile size assessment is difficult. The references are not really based upon large data. So we don't use that. And pubic hair, of course, is a different ball game altogether. That is coming from the adrenal. So we don't really know whether it's going to be significant or not in that regards. The second question is it physiological or pathological? And that's the crux of evaluation because as we discussed, 70% of them are physiological. You don't want to do unnecessary workup in that regards. So when you are looking at, I think the primary role of an endocrinologist would be to think that this is not CDGP. And even a pediatrician will also be there because there you want to work up. You don't want to miss. So as Dr. Sandeep has clearly said, that children with CDGP generally tend to be on the shorter side. They do not have a pubic hair development. They have a delayed bone age. They don't have a pubertal onset. So if somebody already has pubarchy, somebody has a normal growth, puberty started and then stopped. There is a stalled puberty. And if, of course, there is a micropenis history, you are not dealing with CDGP. And this could be a sinister pathology. This is what was the second case I talked about. A boy who presented with normal height, pubic hair development, stalled puberty, and was labeled as CDGP, but turned out to be a craniopharyngioma. So we have to be very cautious in that regards. So we already discussed this about what CGGP is all about. The options to evaluate, of course, clinically are there, but also we can look at various other clues for diagnosis. So if there is a strong family history, particularly of delayed growth in parents, this could be both father or mother. This is an autosomal dominant condition, so can affect both. So delayed onset of menarche, continued growth of father during college years, delayed shaving, all these parameters are there. Other tests include the use of GnRH stimulation test or HCG stimulation test, inhibin B and testosterone. Now, inhibin B is a good marker in terms of predictor as far as puberty is concerned. We'll touch base a bit when we talk about biochemical evaluation. So if you have a child who has retarded growth and bone age, there are no pubic hairs, testicular volume is more than 1 ml. Typically, GnRH stimulation test has a LH more than 5. And you have got a detectable inhibin and a testosterone, then you can clearly say this is CDGP. However, if somebody is not short, has got some pubic hair development, testis is very small and soft, and there is blunted response to GnRH, low levels of testo and inhibin B, it is more likely to be permanent HH. However, the gold standard in terms of differentiating the CDGP or self-limited delayed puberty, which will be a more appropriate term. Remember, 10% of boys with quote-unquote CDGP have normal height. So the term of growth failure may not be appropriate. That's why we use self-limited delayed puberty. And permanent HH is actually how do they do on follow-up till around 18 years of age. So you cannot wait to that time. That's why you want to do all these workup to identify from that perspective. So the next question is, once you know that this is a pathological cause, then you want to know what is the underlying pathology. For that, again, as we've always been focusing, clinical examination will give you a clue. If you have a large testis which is not producing testosterone, as I said already, which means Sertoli cells are more. Classical picture is hypothyroidism. If, however, you have got small and soft testes, this is classically GnRH deficiency. You have got some enlargement, but not big enough. That is constitutional delay of puberty and growth. If there are small and hard testes, that could be Klinefelter syndrome. And rarely, we have seen a few cases of late which are anorchia, in which they had some development to begin with and then testes are lost either in the fetal period or in the early childhood period, they will behave like that. So the most important thing to look at is testicular volume. And second, of course, is the pubic hair. So if you correlate your testicular volume and pubic hair, I discussed this about in girls with delayed puberty, equally important in boys with delayed puberty as well. So if you have a small testis but good pubic hair, it means adrenals are working fine. This is GnRH deficiency. If you, however, have a slightly bigger testis with no pubic hair, which means it's most likely CDGP or illness. A child who is sick in this scenario will have a systemic illness. Otherwise, your diagnosis will be CDGP. If the testis is big, but there is no pubic hair development, this is classically hypothyroidism. And if you have got a child who has not that much testicular development but a lot of pubarchy. This is what we see very often in obesity. So obesity is an interesting phenomena. Obesity will cause early adrenarche because of insulin resistance and advanced bone age. There may be delayed puberty in terms of gonadarchy because of high estrogen levels. Your fat is more, the fat contains aromatase, estrogen is more, it suppresses the LH-FSH, and that's why you will have a blunted gonadarchy and an accelerated adrenarche causing this sort of a picture. So looking at testicular volume and the pubic hair will give you real clue in terms of diagnosis. Now, you can always look at other clues. So, if somebody is really obese, there is hyperphagia. Think of Lawrence bone beetle, Prader-Willi, Alstrom. Already Dr. Sandeep had talked about that. If somebody is very short, think of multiple pituitary hormone deficiency or a systemic illness. Polydactyly may happen with Bardet-Biedl syndrome, and anosmia can happen with Kallmann syndrome. So, the very important thing to ask is whether you can smell. There are definite tests also which are available for that. The presence of hypertension in this scenario suggests that there could be a biosensitive defect in the 17-hydroxylase region. As I said, we are not focusing about atypical genitalia, but if there is hypospadia, that means that the hypogonadotropic hypogonadism is extremely unlikely. You're dealing with a testosterone biosynthetic defect, steroidogenic defects, or action of testosterone is defective. A word about hormonal assessment. So if you can see, the testosterone levels will rise immediately and then they will fall. And these levels will remain very low throughout your childhood to rise again during puberty. So in the prepubertal age group, testosterone is totally useless as a test. During that stage, AMH is a good marker. This is very, very high. So in this scenario, you can use AMH if you want to confirm that there is an abdominal testis, especially in the setting of somebody you are thinking of anorexia. However, what you see is that before your testosterone rises, there is a rise of inhibin B. AMH has gone down. So this time inhibin B is the best test. So inhibin B will predict the development of puberty maybe 6 to 12 months before your rise of testosterone. That is why if you ask me one test which is very, very helpful in this regards, it is inhibin B. If you combine testicular volume with inhibin B, you will get the clear picture in most cases, and that's something which is extremely important. So for very early prepubertal age group, AMH is good. Subsequently, you can use inhibin B. Testosterone is not a good marker. HCG stimulation test is something which can give you an idea, but we don't use that very, very often in that perspective. Now, whenever you are measuring testosterone, you have to correlate testosterone with LH levels. There is a log linear relationship between testosterone and LH. If your testosterone is low, LH should be sky high. So if your testosterone is low and LH is not high, so even if it is normal, this is hypogonadotropic hypogonadism. If your LH level is extremely high, it basically means it's a primary hypergonadotropic hypogonadism. There could be rare scenarios in which your testosterone is high and still the child has delayed puberty. In this scenario, if your LH is also high, means testo high, LH high, basically means testo is not working. So this is androgen insensitivity syndrome. And if you have got a low LH with high testo, it means there is an exogenous testosterone which was given, which can cause this picture. So often boys will go to some person, quack or something, they will give them testosterone. So there is some development, you don't really know whether there is a delayed puberty or not, and you get the report, you say, okay, LH is very low and testo is high. What is the cause? They have given the injection, just like the exogenous steroids, which are often given in these scenarios in that regards. So just to summarize on our flow chart, start off first with screening test. Do not do anything unless you have proven that there is no liver disease, kidney disease, thyroid, celiac, all those things are ruled out. Then if your gonadotropin is high, you're mostly dealing with hypergonadotropic hypogonadism. 99% testosterone will be low, do a karyotype. This is your typical Klinefelter syndrome. If, however, rarely your testosterone is high, you may have a androgen insensitivity syndrome, do a DHT. If it's low, it is 5-alpha problem, or otherwise it's androgen insensitivity. The confusion happens usually on the right side of the algorithm. If your gonadotropin is low, you may have a CDGP. you may have a systemic illness, you may have a permanent hypogonadotropic hypogonadism. You would, of course, have already excluded a lot of systemic disorders by now. So then you ask for pointers of hypogonadotropic hypogonadism. So if you have a boy who has got micropenis, undescended testis, anosmia, synkinesia, CNS features, and a low LH, don't need to worry much. This is permanent hypogonadotropic hypogonadism. Consider MRI and other tests as well. In the absence of this, look at testicular volume. If testicular volume is more than 3 ml or 3 ml or something like that, it means that you're pretty much entering puberty. If it's less than 1 ml, then becomes difficult. In that case, you do an inhibin B. If it's low, this is permanent HH. If inhibin B is high, or if the TV is more and inhibin B is more than 100, this is diagnostic of CDGP. On the other hand, if you have got a testicular volume less than 1 and inhibin B more than 50, or a TV more than 1 and an inhibin less than 100, then you can do a GnRH stimulation test to classify into a permanent HH or hypogonadotropic hypogonadism because of a constitutional delay of puberty in growth. So if you look at the algorithm, this may look confusing, but simply do the screening test first. High levels of FSH, do a karyotype. That is very simple. If the LH-FSH is low, then you start thinking of permanent HH. Look for clinical features, absent, very small testis, get a inhibin B, low, this is permanent HH. If it's testicular volume of 3 ml, inhibin B is high, that is CDGP, in between do a GnRH stimulated test. So we are not giving that much importance to the basal testosterone. We're not giving that much importance to HCG stimulation test. And in most cases, you will get the right diagnosis using this algorithm. So we have now 14.5-year-old boy with delayed puberty. Family history there in father, height is 148, weight is 45, testicular volume is 2 ml, pubic hair is stage 1. So Dr. Sandeep, what are you thinking of? So you have a short child who has a small testis and no pubic hair. Yeah. So this is fitting into CDGP. Screening tests were done which was normal. There were no pointers to HH. Testicular volume is already 2 ml, more than 1. Inhibin B is 125. So this is classically you're dealing with a case of CDGP. Second scenario, 15-year-old boy with delayed puberty has a small phallic size at birth. He is not short for the family. Weight is normal. Testicular volume is 1 ml soft. So how is he different from the previous case?
First of all, small phallic size against CDGP, and this height is again against CDGP, and the testicular volume 1 ml is again.
So this is just subtle differences, but they will give you a good enough clue. He also has stage 3 pubic hair. So there is everything written that this is not CDGP. Micropenis, normal height, very small testis, and pubic hair, which basically mean that you are dealing most likely with a permanent HH. There were no pointers of HH. Inhibin B was low. So then you make a diagnosis, this is permanent HH, and then you can do further evaluation. This case I've already discussed, that 16-year-old boy who had an onset at 13 years, stopped for 2 years, small testis, pubic hair is there, and labeled as CDGP, but this was actually a large lesion which was sitting there. So don't be very scared of stalled puberty. That is worse as compared to delayed puberty. 16-year-old boy with delayed puberty, testicular volume is again 3 ml, no pubic hair, very, very short. And the weight is also less. Bone age is delayed. He has low LH, low FSH and testosterone. Labeled as hypogonadotropic hypogonadism. Advised MRI head. Do you agree? Yes. So this, yeah. So this could be a multiple pituitary hormone deficiency. It cannot just be a simple hypo, or this could be a systemic illness. So in this case, he had anemia and celiac has to be considered in this scenario. 15-year-old boy with delayed puberty had micropenis. Height is 162, testicular volume. This I think we already discussed about that. If we just compare this table, we will find that their classical feature that the bone age is 14 years, which goes against CDGP, and this is likely HH. And the workup basically showed a low testosterone and no response, and there is anosmia. So now, which genetic defects are out if there is anosmia? So this will be post-migrational will be out. So something like KISS receptor, KISS1 receptor, GnRH, GnRH receptor, you're thinking of either an NOS1 defect, FGFR1, or CGH, CHD7, all these things could be likely in that regards. Now, in this regards, you can then plan thinking of giving testosterone in this case, and with testosterone, they will improve, but the testicular volume is not increasing. So this is expected. This is a permanent HH in that regards. 14-year-old boy with delayed puberty, testicular volume is 1 ml, pubic hair stage 3, height is 142 centimeters. So he is short in that regard, but he is very obese. And LH, FSH is low, pubic hair is there. So what do you think?
This is obviously
So this is because of obesity, differential effects on gonadarchy and adrenarchy. So your DHEAS is good enough, and that's why there is development. But the other feature is that he is very obese. Delayed puberty is hardly anything for 14 years. What is more concerning is weight of 82 kgs. So there is hyperphagia. So you have to think of a Prader-Willi as a possibility as well. 17-year-old boy with pubertal concern, he had an onset at 12 years. But now, since 3 years, he doesn't have any development. There is firm 2 ml testis with gynecomastia. What do you think is this clinical picture?
the stall puberty, sir. The form small testis with gynecomastia points towards Klinefelter syndrome.
So this is a classical case of Klinefelter. You have got a high LH, FSH, testosterone is low. So this is Klinefelter syndrome, as you already discussed. 15-year-old boy with delayed puberty, there is a history of penoscrotal hypospadia surgery. So this is even worse than micropenis. So there is something going on. Penile length now is 7, pubic hair is stage 4. There are inguinal testes which are there. What do you think is happening?
There was a history of penoscrotal hypospadia at birth. So there is defect in the testicular action or testicular conversion, sir.
Synthesis, action, conversion. So all those things can be there. LH and FSH are high. Testo is also high.
Testo is high, then we have to look for the DST levels.
Yes. So DHT was suggestive of partial AIS. So you've got a high testo, high LH, which means androgen insensitivity. So we have developed a puberty interpreter which helps in terms of evaluation of both delayed, precocious in both boys and girls. And this has been found to be effective. You can use it. The tool is available online. All of you can go and have a look at our website where a lot of publications are available. Our app, which will help you in terms of evaluation and management. Join our courses and look at free resources in our website.